Hello, quality-minded listeners. Welcome to Key into Quality, a Mayo Clinic podcast focusing on healthcare quality trends and solutions. Every day in healthcare, near misses and safety events happen. But how do we ensure that we're learning from them and making care safer day by day? At Mayo Clinic, a dedicated team works behind the scenes to ensure that safety reporting isn't just a checkbox, but it's a powerful tool for change. Do you want to learn more? Let's go. A special shout out to our Mayo Clinic Care Network members. Thank you for joining us. I'm Dr. Tim Morgenthaler, a professor of medicine here at Mayo Clinic and a vice chair of quality. My co-host in Key on Quality is Sherry Nemec. Sherry?
Hello, everyone. I'm Sherry Nemec, Consultation Relationship Manager for Quality at Mayo Clinic. And, in thinking about this, Dr. Morgenthaler, I think in healthcare, we have most of the time so much data and we don't do anything with it, right? We don't use that data to create meaning or in a purposeful way. So I think what we'll be talking about today will be really helpful.
Sherry, you raise a really good point. We are lucky to have lots of data, but that does occur because people take time to observe and report. And so that's a lot of what we're going to talk about today is, how do we take in all this information? So we're talking about something called the Safety Electronic System Oversight Team, which is a group dedicated to ensuring that Mayo Clinic's electric safety reporting system meets the needs of our practice and also meets regulatory standards and especially meets the requirements of our patients. This system isn't just about logging incidents and reporting stuff. It's about, as you said, collecting meaningful data, facilitating process improvements, and driving innovation in patient safety. So joining us today are two experts in this space, Joe Nienow and Dr. Jennifer Cowart, who will walk us through how Mayo Clinic is aligning our technology, strategy, frontline feedback, and all of that to make a more effective safety reporting system. So let's go. Joe Nienow, can you please introduce yourself for our listeners and just tell us a little bit about yourself?
Sure. So Joe Nienow, I am our systems manager for patient safety. So managing the electronic system as well as with our EHR integration.
And tell us a little bit about, like, when you say electronic systems, what exactly are you talking about?
Sure. So we have an electronic reporting system that's open to all employees, as well as integration with our electronic health record. So feeding back and forth.
Super. And of course, we're pleased to welcome back Dr. Jennifer Cowart, who has been a patient safety officer at Mayo Clinic in Florida. She serves clinically as a hospitalist there, and I believe now she is the chair of their quality subcommittee. So, Jennifer, just remind our listeners a little bit about yourself.
Thank you, Dr. Morgenthaler. It's good to be back. So I'm Jennifer Cowart. I'm a hospitalist and internal medicine at Mayo Clinic in Florida. I'm an associate professor of medicine here. And since 2024, I have served as chair of quality for Mayo Clinic in Florida. And for several years, I was the physician chair for the SESOT team, the systems team that we're going to be discussing today. It's really good to be back.
Yes, and welcome back. So actually, let's start with that. SESOT. Is it a disease or a committee? Tell us what it is.
Well, we love a good acronym around here. So SESOT stands for Safety Electronic Oversight Team. And what this came from was, first off, a clinical need that was brought forward over many years. We were using a legacy piece of software for our event reporting system. This is where people would report incidents, safety events, near misses, and we were using a piece of software that was no longer meeting our needs. Throughout the 20 teens, this was growing in need of the need to replace this system. But what was also recognized was that simply buying and installing a new software system or creating a new software system was not by itself going to meet our needs either. We needed a team, a multidisciplinary group that would oversee not only the project to identify, select, build, and roll out the new software, but also to continue to iterate and improve on that software. Any piece of software is only as good as how people are able to interact with it, use it, develop with it, learn from it. The system needs to learn, we need to learn, et cetera. So many leaders across Mayo Clinic at the patient safety and quality enterprise level recognize the need to install a team. And for short, we called it SESOT because it was too much to say the other way. But SESOT really started in the project phase with the identification of the new patient safety event reporting software. SESOT then oversaw the project implementation in stages. So stage one was the initial rollout, stage two being kind of the break fix phase, if you will. If something wasn't working right, a form, a field, et cetera, we were the team that would take those in, get them to the build team, get things fixed. And then into stage three is continuing iteration, ongoing improvement in this system. So this is a data collection system, but it's also a data aggregating and then reporting system. So how do we learn from the just truly gargantuan piles of event reporting data that we receive from Mayo Clinic staff? Just for quick comparison, we used to get something like 4,000 event reports per year here at my Florida campus. And now we are something like 8,000. I mean, it's just a
Wow.
staggering volume
Yeah.
of times and chances our staff tell us that we need to fix something to get it right. And so we need a system that learns with us so that we know how to act on those opportunities to get things right.
So I want to go back a little bit towards the beginning of what you were saying. You said that back in the teens, we were recognizing a need that our current system was not filling. Tell us a little bit about that. I mean, what were the needs that we were recognizing, or that your team was recognizing, that really started this whole thing off? What were the requirements that were not being met?
I'll give a couple and then I'll see if Joe has anything to add. So I would say first, just big buckets. So the needs of the frontline reporter. This is the staff member who's identifying that safety challenge or unsafe condition or the near miss. The system was difficult to use. It had a lot of clicks. It was difficult to access. It wasn't tied to the medical record. You had to know a lot of information about the patient, the date, the encounter in order to even access the system up front. So we felt that that was probably suppressing the desire and need and bandwidth for people to be able to report.
So in other words, if I wanted to report something, I would open up a different set of software, and the first thing it would say is, what's the patient's name, what's their date, where are they located, what's their birthday or whatever, and all that information is already in the electronic record. So for me, that's like, oh gee, could I please file my income taxes for fun or something like that?
Totally. Income taxes sometimes are more fun.
User interface, very, very big barrier to saying, yeah,
Big
here's
barrier.
something I saw. I want to voluntarily express that this is an opportunity for improvement.
Yeah. So it was hard to use for the frontline staff who needed to report events. And then it was also hard to use for the reviewer staff. This was the staff in patient safety, the staff at the nursing or clinical manager level. It was difficult to access and pull data out of this system. It was difficult for me to access as a patient safety officer. So we weren't getting the useful information out of the system that we needed to actually try to drive change when our staff were giving us those opportunities to fix things. So it wasn't serving the needs fully of either the frontline reporter or the reviewer staff.
And I would just expand on what Dr. Cowart had outlined was, even if we were doing that, we were doing it in separate systems. So it was a matter of bringing all of that together, whether it was Word documents, templates, all of the different pieces. So it just created more time, more work to bring it together, even if we had the information somewhere.
So you talked about, I mean, this was a big lift, right? This was huge to do all the stages that you talked about, Dr. Cowart, and recognizing the need to make sure that we have the human side, the people helping to make this all happen. So who did you determine you needed to be involved? Why did you pick those folks? To say a little more about that.
I can take that piece of it. So really from the start, recognizing we needed a multidisciplinary team to see this full vision. So even from inception of entertaining the idea of looking at new systems, we opened it up, literally sent out questionnaires and opened access to any Mayo employee to give feedback, what they liked about the current system, obviously what they didn't like, what was missing, what they needed. And it really just grew from there. So going back to what Dr. Cowart stated about kind of that build phase. So involving hundreds of people at times and giving feedback on form design, what data elements are critical, what's critical to the practice. And so building on those, also looking to, our reviewers, so people supplying input back. What did they need? What did they want to see? Clearly our patient safety staff as users of the system, what did they need? How could we make their workflows and work lives better, integrating all of these things. So really it was an end-to-end process involving nearly any one of our staff that wanted to have input at some point, and then paring that down. Dr. Cowart, additional.
Yeah, I want to add to what Joe was saying here. So there was the enormous gathering of stakeholder information and subject matter expert guidance for building and implementing the new system. But there was also the multidisciplinary, multi site enterprise approach that was taken for building the SESOT team itself. So the SESOT team has representation from all the sites across our Mayo Clinic enterprise, and we have staff there from patient safety experts, data build team experts, radiology safety, lab safety, clinicians, nursing, pharmacy. We have many groups represented in that team because all of them play such a key role in keeping our patients safe. We need to be sure that not only are we gathering that information on the front end of this project, but also that we're continuing to have those touch points at the CSOT team for that continuous improvement.
So as you all were working on, that's a lot of phase one work that you were talking about. I think it's in the terms of the phases that you mentioned, Dr. Cowart. So phase one, you sought, it sounds like a lot of stakeholder input. And then in phase two, tell us a little bit about that. So once you kind of knew what people wanted and you hunted around for it, you found something, I know, and you started installing it. Tell us about some of the toils and tribulations of phase two, what I think you called the break fix phase.
Absolutely. So phase two was where we have this software. We chose to go with an external vendor, but I think our principles really would apply whether you're going to build your own software or you're going to buy your software. So we took the software, we worked with our build team and the software developer to make sure we had the right forms, that it was linked to our HR software, that we could identify staff roles, staff names, et cetera. And then we picked a go live date and we rolled it out that day. But before then, we had to train 80,000 plus staff. So we had to create a module online. We had to issue this training, and we had a couple different types of training. So we had the training for the frontline reporter that everybody got. And then we also had some training for our patient safety specialists, our nurse managers, clinical managers, people who were going to be reviewing events, because we had to try to teach them how do you use this software tool to evaluate an event. So we did an enormous training rollout across the entire enterprise. And that was a huge part of the work of the team. We did not believe that simply dropping this software off one day and saying good luck, that was going to be successful. We believed we needed to teach and coach to get it implemented. And then in the break fix phase, there's always something that might not work just right off the bat. And so I think just to be prepared for that and to accept that that is normal, but that the system overall worked very, very well on day one. People were able on day one to log in through the EHR, find the patient safety reporting link out to that browser. It is still in an external browser, but now it includes encounter information and patient information without the frontline reporter having to type that in. So on day one, we were prepared enough that that part worked, and then we were simply fixing little form names or other things, and we had a simple path for people to report those to us so that it was expected. We deputized our staff, help us fix the system when you see something broken, help us know how to fix it and make it work better for you. I think those were all really, really important tactics.
Joe, anything you want to add that comes to mind as well for tactics or barriers or?
No, I think Dr. Cowart covered it very well. One of the things that we did have to overcome is really working in an engagement in that culture of safety piece. So I see that as really twofold. Talking about our legacy system, it was very closed. It was very patient safety staff centric. They were really the only ones that worked in it, were able to extrapolate data from it. So now it's open to, as Dr. Cowart said, really 80,000 of our staff can go in at any point in the day, report an event. They may ask to be a reviewer on an event or give some input based on that. That's a real shift where we're not closing off that information. Reviewers can see other comments. It's very transparent, and we're learning from the system from the start. And the other piece of that is really the data aspect. So again, historically very closed off. Now, obviously based on some access levels and things that we've built in behind the system on need to know, containing PHI, those types of things. But any of our Mayo staff to some degree can go in and look at data. They can see trends, they can see what's happening around the organization. So very open.
So I'm going to go a little bit into the weeds here, but it's because I can't help myself. So we haven't gotten to phase three yet. We definitely want to get there, but phase one and two, you did this huge stakeholder analysis, and we heard about some of the deficits of the old system. What things were you really looking for eagerly in the new system that the old system just didn't have? There were some things I bet that you identified that you said, wouldn't it be nice if?
Yeah, I think and I'm going to touch on this again, I think, because this is such a key point for me. We kept a first principles approach throughout the whole project. We tried to keep it our principles simple, and one of the principles was keep it simple. We heard over and over and over again that if the system's too hard to use, staff won't use it, and that especially is a suppressor for those frontline staff. So when we were looking at new software to, again, either develop or purchase, we were looking for, does this deliver what we need on those first principles? Is it easy to use? Will it integrate with our EHR? Will our reporter staff be able to use it to report those unsafe conditions? Will our reviewer staff at all levels of review, from the nurse manager who's getting that initial review to a patient safety specialist or manager to someone doing a root cause analysis, will everybody be able to use this system with just a little bit of training and some reference guides, but it's easy enough to use that people will not find the software cumbersome and they can get to the meat of what they're doing, which is actually investigating these conditions. So starting with a first principles approach, we were looking for, in this case, we were purchasing software, but we were looking for a software that we would be able to keep it simple, that it would do what we needed, that the developer was going to be able to work with us, that we would have the on-site capability plus their capability to do what we needed to do. We did not expect to buy something right out of the box, install it with no modifications, and it was just going to work for us with no additional mods. But we also didn't want something that was going to be so complex that we wouldn't be able to use it. And so I think starting that first principle approach was extremely important. And there was one other thing that I just want to level set here. Perhaps some of our listeners at different organizations, you may have event reporting software that is confidential. It is anonymous. It does not provide for the name or identification of the reporter of an event. At Mayo, our legacy software was already a transparent software. It was not anonymous. It was already identifiable who reported an event. We felt that was extremely important. We believe fully in this transparency because I need to be able to talk to someone who reported an event and learn more. And so we were looking for that capability in the new software as well, that we wanted transparency. We wanted even greater transparency. So if I am routed an event and I say, I need another expert to look at this event, I can route them. I can see their comment. They can see my comment. We can have a dialogue in the software. So again, that might differ at your organization, but for us, it was extremely important that we have transparent software and that we were able to stick to that as a principle. And that was something we were really looking for.
I also want to just get your insights on the word review, because I'm kind of imagining. So I'm creating a scenario here. I'm out in the front line and I see somebody who fell. So I want to make sure that we report that fall, because that's an important thing to know about in addition to taking care of the patient. So there's one level of review. I imagine when you're saying like the unit supervisor or the head nurse, they're going to want to review the facts of the matter, make sure that all the facts are known. Was that patient assisted, unassisted? Were they on medication, not on medication? All those kind of things that you get in there. But then there's other levels of review. It's not like the unit is going to review the details. Tell us a little bit about what other reviews you were talking about. Maybe Joe, as you were going up the organization, what is the review? I think it may mean different things at different parts of the organization.
Yeah, great question. So as you alluded, the nursing staff immediately involved, but then we also need to go, whether it's from a regulatory need or just an institutional need, that we want to review something in greater depth. So going through the common cause analysis or a root cause analysis historically, so we can bring all that information together with our patient safety staff, with our administrative partners, where that applies. But then even going beyond that, so looking at taking all of those learnings, so it's, I think what we've learned over time is it's not event specific. Some of the things tend to happen over and over. And so being able to bring those things forward and continue to learn each time is, we don't want to compartmentalize these things. So being able to learn from each one, each event, grow, expand the knowledge. So the system should allow for that type of capability where we can bring together not only event specific information, but that trended analysis piece.
So let's jump ahead now. You're live. You're in that stage 3. What are the things that you're seeing? Yes, that's right. Yoo-hoo! We made it to live. What are you seeing? What are you actualizing some of the improvements you hope for? Tell us the rest of the story.
Yeah, so let me start with in our early go live after we've taken care of the initial tweaks and we said, okay, now what are we doing? So one of our data analysts on the SESOT team, shout out to Matt, has really been instrumental in helping build out some visual reports of our data that we can use. And primarily, we were starting off using a Tableau, but the name of the software is not what's important here. It was that we were able to graphically represent, first off, just numbers. First off, just is the system working? Can we see numbers of events that are reported in the system? Then we started to report out in this system, identified potential harm levels after events were adjudicated by patient safety staff. So we developed our Mayo Clinic harm scale, and then we were sharing this within our teams in, again, this is Tableau software, but it could be any software. So we were able to share that amongst our teams. Then Matt would listen to us in CSOT or other groups, and we would say, well, we need a report for, again, falls. Falls have come up. So what report can we get on falls? Can we drill down to the site level? Can we drill down to the hospital level or even to a unit level? Can we drill down by the fall type? Was it witnessed, unwitnessed? Was it assisted, unassisted? Was there harm from the fall? And then trying to drill that down. So the first things that we did in improvements, I think, were really around data reporting into, again, a Tableau. Now we're going to be adding Power BI technology to that and better able to graphically represent our data as well as drill down. But the next thing I want to say is I'm going to use falls again as our example because they're such a good one. We identified needs to make that reporting even simpler. We identified that our nursing staff came to us and said, we're kind of double reporting this. We're having to describe it once in the EHR because this is a thing that happened to a patient in our facility and we need to be able to describe what happened in the EHR. But we also then have to kind of go copy paste it almost into the event reporting system. Can't we make that easier? And so we listened. We said, yep, that sounds like a great thing. We can reduce that double effort. And so we are working currently, and I believe it's in a go live state, on an improved fall navigator so that staff are able to report it in the EHR, open up the patient safety reporting system from the EHR, and just about everything that they need to report into the patient safety reporting system is going to be carried over, trying to reduce that double work.
It's tax season because I thought immediately of a TurboTax-like function where, you open it up and your W-2 gets sucked into the report instead of you having to enter all that stuff. So,
Right.
Yeah, absolutely.
So falls navigators, data visualization, trends, what things have you learned recently from the system since you've gone live? I think it's been live now for maybe over a year.
Yeah, a couple years now, actually. We went.
Wow.
Yeah, time flies. It really does. So I'll start off, and then I think what we also want to talk about is some of our visions for the future. So big learning for me so far has been the real difference in needs of the frontline reporting staff and the reviewer staff. So we will get sometimes a change request from especially our reviewing staff, the staff who are reviewing events and errors or unsafe conditions. And I'll pick med errors as one. This is a team that's been very engaged and is bringing forward a lot of change requests and change optimizations. And when they first came, they said, wouldn't it be great if the frontline staff could make a bunch of click boxes and enter a bunch more information that would make our lives easier as reviewers? And we had a really open dialogue about, we understand that would make your life easier as reviewers, but it also is going to make life harder for the reporter. It may suppress their ability to engage with the system and report. Is there a middle ground somewhere? Is there a minimum amount of information that you can glean from the frontline reporter that would be helpful to you, but it would still make your job easier in doing these reviews because you're reviewing a lot of them? And again, anything we can use technology for, what can we start bringing more information from the chart automatically, et cetera. So this is one that's in the works. But for me, I think trying to balance these two groups' needs is sometimes a challenge. Having a clearinghouse like SESOT where we can hear from both sides directly and they can talk to each other and people can recognize, oh, that's what you're seeing. This is what I'm seeing. I continue to believe this is valuable. So again, we didn't visualize SESOT as just a project oversight team. We did not sunset it once we rolled the system out. We left it in place for that oversight so that we can continue to bring these teams together. And then I think Joe wants to talk about some of the ways that we want to continue working on our data because we're gathering just reams of data. What do we do with it now?
Thank you, Dr. Cowart. And just one thing before we move on to kind of expand on this topic of SESOT is really that highlights why we have this multidisciplinary group, because reporters, reviewers bring forward an idea like the medication and the additional checkboxes. And we have some amazing staff with our clinical informatics, with our EHR backgrounds, all of those people. So we can really see things differently than maybe we had historically. Can we work a different way and achieve the same outcome? But with all these great minds in one room, in one meeting, we can vet those things out and get the same end goal without creating the same lengthy reporting form. So appreciate that comment, Dr. Cowart. So really taking that and moving forward, we continue to do that EHR integration. I think that's current state and a bit of future state, but really looking down the line and things that we're working on today is, the things lots of practices are looking at. So the AI and large language modeling, how we can leverage that near state to look at those processes for reporting, for triaging, harm level, review, all the pieces up front that take a lot of time, take a lot of effort, very staff intensive. What can we use those processes for to really allow us and expand time to focus on the proactive approach instead of continually reacting to every single event individually? What we can do and where we can focus our efforts, our FTE really is what it comes down to. And we want to focus those things on the proactive approach.
Yeah, we're gathering just tons of free text data in a lot of these systems. And so it can be difficult for the human reviewers who are looking at these individual event reports. It can be very difficult to identify what is trending. Our patient safety staff who review these have excellent memories and they can often recall, oh, I think I've seen one like that before. But I think this is an excellent use of the growing AI technologies to help surface those trends easier so that our patient safety staff are then able to pick up those two cases. Maybe they're 2 years apart or they're at different sites of the enterprise. They can pick up those cases, look at them, quickly learn what is similar and what is different about them. This is a great use of technology that enhances the capability of the human reviewers in the system to do their job.
Kind of like Netflix makes suggestions of what movie I might like to watch next. Our AI can look through the database of safety events and comments and say, hey, this is a lot like this other one, and you should look at this.
Exactly. This event is just like British Bake Off that you watched before. Wouldn't you like to see this event too?
You're on to me now, British Bake Off. There you go. Well, listen, this is an amazing amount of work. I know it took a long time and a lot of input. In part, that's because we're a very large organization, and we really feel how important it is to do this right, do this well, learn on behalf of our patients. But what would you say to an organization that wants to just start work in this area? Maybe they're also feeling that, gee, our old system isn't quite living up to what we need. What would be your advice about starting this new trip?
So I'll start, and I think Joe's going to close us out. So I would say start and keep to your first principles. So for us, that was make the system simpler and keep it simple. And we've really stuck to that over the several years of this project. We use that guiding principle to this day to inform how we respond to change requests. If something's got too many clicks, we need to make it simpler before we can implement that change. Now, we work with the practices to help them identify how to take their vision, what they're asking for, how can we work together to build that into our system. So the answer isn't no. The answer might be, let's make this meet our first principles before we implement this. But I would say whether you're building your software or buying your software, however you're approaching this, what is your first principle? Keep that in mind. Keep it going well after you roll out the software and continue to evaluate any change requests that would go into that system so that you're not undermining your first principles. Joe?
Yeah, great thoughts. And I would go back to getting all levels involved in this process from the very start. And also just understanding that this isn't a once and done type of process. It really is an evolution. So you don't want things stagnant as technology changes, as healthcare changes. Keep in mind creating something that can change with it instead of being outgrown.
Great point.
Yeah. Well, listen, you two, Sherry and I just want to express our gratitude to both of you for sharing your time and your expertise with us in our discussion today. And on behalf of our listeners, I also express gratitude to you. I'm sure they found this information useful. And actually, as a clinician and a patient sometimes at Mayo Clinic, thank you for the work that you do to help keep us all safe. Really appreciate it. So we've come to the end of our podcast. We're glad that you could join us, and we hope the information has been helpful to you. Again, Mayo Clinic's Key into Quality podcast aims to highlight some first steps in addressing important quality challenges in your organization. Our goal is to improve quality for patients and populations that we all serve. If you enjoyed the podcast, we'd be grateful if you left us a review on Apple Podcasts, a rating on Spotify, or feedback wherever it is that you listen. You can also follow us on your favorite podcast platform. Let others in your organization know about the podcast so the information can be spread and make a better world. Until next time, thanks.